Good morning everyone. In this video I will be showing the way I do ossiculoplasty. Ossiculoplasty forms an integrate and important step in tympanoplasty surgery. However, various methods, various implants and various materials like homograft, allograft, autologous materials have been used to reconstruct the sound conducting mechanism that are ossicles in the field of otology. In my practice, I have tried lot of alloplastic materials in the beginning. As you see in this case, it is a intact canal wall tympanoplasty where I am using Teflon PARP as short columella. I am making the PARP to sit on the mobile stapes. This is a modified radical mastectomy where TARP is being used from footplate to neotympanum, and this is the well-healed drum with a vibrating tympanic membrane ossicle you can see. This is a long process necrosis is there where I am using lenticular process necrosis prosthesis. In this patient is an intact canal wall technique where I am using a titanium PARP as a short columella and a piece of cartilage is being kept on that. I have noted many of my patients where I used synthetic materials like this, there was exclusion of the processes like this. I also used a grommet in between a lenticular process necrosed incus and the stapes. To look it was better, but post-op patient had some problems. So then I stopped using all the alloplastic materials and I started using the homograft ossicles or the autologous graft. You can see in this patient I am using a septal spur cartilage, homograft septal spur cartilage, a short columella. I am making a facet to sit on the stapes as a short columella. I am made a small cut in the cartilage as you can see, which exactly fits on the stapes and the stapedius tendon. This is an intact canal wall technique wherein the stapes is mobile and the long process was necrosed and there was cholesteatoma around it, it was removed, and now I used a malleus head to sit on the stapes by making a small facet on that you can see. In this presentation you can see this is a incus is removed and the same incus being used, sculptured. You can see the incus being sculptured and a facet is made in the by taking a 0.6 burr, and this incus is going to be made sit on the mobile stapes. You can see it's a tight and good assembly. It is the process is unlikely to fall. This is a canal wall of tympanoplasty where I am using a malleus of the patient, same patient, and to sit on the foot plate to the neotympanum like this. This is a intact canal wall technique where I am using the patient's own incus to sit on the foot plate like that. It's a good assembly, it's unlikely to fall. And in this case I also use a small piece of conchal cartilage which is extending from the hypotympanum to onto the stapes so that it will maintain the middle ear space also. Now we can see some of the techniques that we do in the canal wall down technique. So now you can see this is a canal wall down technique done for cholesteatoma where there is a intact and mobile stapes wherein I am using the autologous bone which is sculptured and it is made to exactly the head of the malleus where it is exactly made to sit on the mobile stapes you can see, and this should not be too long so that it will have a tenting effect like that. And you can see canal wall down technique. Same type of scenario where the stapes is mobile, and here in this case I am using the septal spur cartilage, homograph septal spur cartilage. So you can use the autologous or homologous head of the malleus or incus or septal spur cartilage. So I made a facet with the 0.6 burr, and this septal spur cartilage is made to sit on the mobile stapes. You see, this is a very good fit where it is unlikely to fall. And in canal wall down technique, you can see I have taken the patient's own malleus, and it is sculptured in this way. The way you sculpture it is like a boot shaped. You can see just below the short process I made this one, and you can see the malleus is actually a curved bone where you can make it straight also this way, because the curved bone, it is very difficult to make sit on the foot plate to neotympanum. So you can straighten the malleus like this so that it will not have any problem in keeping on the foot plate. You can see that I am making the malleus straight with the suitable size burr. All this ossiculoplasty, whatever material you use, it has to be held by a Derlakis ossicular holding forceps. And now you can see the boot shaped lower part is going to sit on the mobile stapes like that. So before we keep anything on the foot plate, we have to keep a small piece of fascia. So again, you see, this is a canal wall down technique where I am using a long columella technique. This is where using a septal spur cartilage which is preserved. All this septal spur cartilage, homographed ossicles are preserved in the 70% alcohol. And see, a small piece of temporalis fascia is kept on the foot plate, and now I am making the cartilage to sit. This is a nicely fitting there, and we need to increase the mid-ear height there. Yeah. To conclude, ladies and gentlemen, the search is there for what is an ideal prosthesis. The ideal prosthesis should be the one which is easy to sculpture, cheap, and with low excrusion rate, and the results has to be reproduced by the average surgeon. In my hands, homographed or autographed septal spur cartilages or the ossicles are doing better. So I stopped using the alloplastic materials because they have got high excrusion rate, and these autographed or homographed materials are giving excellent results in my hands. Thank you very much for your kind attention.